Welcome back, everybody. I have the pleasure of chairing this session. My name is Associate Professor Kirsty Short, and I'm from the University of Queensland. And today we're going to have quite a diverse session, ranging from influenza vaccines all the way through to non-infectious diseases. So I think it will be a very good session. Without further ado, I would like to introduce our first speaker, who's Professor Paul Van Binder from Griffith University, and he's going to be talking about to us about influenza vaccines. Welcome, Paul.
Thanks, Kirsty. So I wanted to give a bit of an overview of where we are with influenza vaccines, having a look at where we started, the point we're at, and the potential moving forward in the future. This is a list of disclosures from various people, from various companies, and I want to highlight the fact that I've received slides from lots of people that I've used in this, including some of the vaccine companies, but the views expressed are mine. So when we look at why our flu vaccines have failed us so often in the past, there are actually four major factors that come into play. Sometimes these are viral factors. We take a candidate vaccine selection 6 months before the start of winter in order to allow for production, and then we see antigenic drift or shift in the circulating flu strains. Sometimes they're factors in the vaccines themselves, that because some of the viruses don't replicate very well in the egg-based production process, they adapt in order to grow better in eggs, and then in fact are different from the candidate vaccine and thus different from the circulating strain. Excuse me. We're all very well aware that there are patient factors, that these vaccines have not worked well in the elderly, largely because of a combination of both immunosenescence, reduced functioning, but also inflammaging a continuous battle against chronic infections like CMV. And then fourthly, utilisation factors, which can be quite significant in some groups, lack of patient demand or a lack of provider recommendations, particularly in groups like pregnant women. So the challenges we face are we don't know what's turning up, whether we're going to have a big A year or a big B year or a combination of those, and the vaccines work differentially against different strains. And this is clearly incorrect. This prediction that flu is coming in less than a month, we saw this year, particularly after 3 years of quite late 2017, 18, 19 flu seasons that peaked in August and continued through to September, October this year. Flu was pretty much finished by the middle of July. So that's important because particularly against H3N2, the vaccine effectiveness declines during the influenza season. And in some cases, particularly against H3N2, what we found is in fact that after about 4 months, the vaccine is ineffective. So if we're giving it in March and we have a late flu season, then we don't have any benefit of that at all. And finally, the breadth of response may not be sufficient with flu vaccine. And flu vaccines work obviously much better when we have a matched vaccine circulating virus season than they do in mismatched season when there is significant drift. So in the past, essentially we've used first a trivalent inactivated vaccine, moving on to a second B strain and a quadrivalent influenza vaccine. It's been free for some people in Australia, and everybody be aware of the groups, the young, the old, the pregnant ladies, those people with some chronic diseases. We've recommended it for all people, despite the fact making it only free for some. And pre-2017, I think most of us would agree that coverage was reasonably poor, particularly in target groups other than older persons. We've had a series of enhancements over the last decade, most of which turned up and then disappeared. Some people will remember the intradermal vaccine that became available. We thought that that was going to be a great improvement because of the local enhanced antigen production cell attraction capacity, but ultimately it suffered from a combination of some increased reactogenicity locally and some increased cost, which was intolerable to the Australian market, and it disappeared. And then, my particular disappointment was, and here you can see the wistful ferret wondering why we can't make LAIV great again. This was a vaccine, a live vaccine recommended preferentially by CDC in the US for children, ended up having not as good a response as TIV in 1 year over there, which was put down to heat lability in the H1N1 strain. The vaccine then failed again in the US and was actually withdrawn from any recommendation rather than being preferential. It's now available again in the US. There's no signs that it's going to be here, but it had much better data in Europe. And this is the vaccine that is actually used as part of the Universal Childhood Program in the United Kingdom, and has had some really reasonable data come out in Richard Peberty's studies for the UK system. So we've had enhanced vaccines that have not done things at times. This is what we need. We need an influenza vaccine that have a higher immune response, including in the elderly. We need one with an improved breadth of protection so that when drift and strain mismatch occurs, we still have an effective vaccine, and we need some persistence so that it persists right through to the end of October if we have a late season. Now, we currently are using 3 vaccines in Australia to varying degrees: an adjuvanted vaccine, a high-dose vaccine, and a cell-based vaccine, which are all available in programs in Australia. And this is important because this is some data from CDC. And what it showed was in a bad mismatched H3 season, a drift H3 season in 2014-15, even a very low improvement of vaccine effectiveness of about 5% would give them 86,000 hospitalisations decreased. And so we're going to see much more benefit in actually improving our influenza vaccines rather than getting our coverage rates up with vaccines that work poorly. And I know that there's some work being done by Sheena Sullivan, David Muscatello and others looking at providing similar data for the Australian situation, which hopefully will be able to be used to get us some more enhanced vaccines onto the NIP. So the current manufacturing technologies, and most people still get an egg-based vaccine, an inactivated vaccine that we use with candidate viruses that are identified by WHO. We do have a cell-based vaccine available in Australia now with an inactivated subunit. We have a recombinant vaccine that is available elsewhere, but at this stage not available in Australia. That's Flublok and others that are now part of the Sanofi program. We have 2 that we are using, a high-dose vaccine, which is the same as the routine egg-based vaccine, but has 4 times the content. And we have an adjuvanted vaccine, which is now in use for all of our elderly, an MF59 adjuvanted vaccine. So just looking at those 3 groups briefly, the cell-based influenza vaccine ends up using these mammalian cells It's not possible to undergo egg adaptation because there's no eggs involved. So the problem with the candidate virus changing during the manufacturing process in eggs is removed from that. The rest of it is essentially the same, and we end up with the same sort of processes to produce this vaccine, which is available in Australia for everybody over the age of 2 years. This is some data, and I'm not going to go through data in all of these in detail because I've got 20 minutes, but you can see that these studies in a H3N2 dominant season in 2017-18, lab confirmed medical encounters, hospitalisations, all favoured the cell-based vaccine over the egg-based vaccine that year to different extents with different cell populations and so on. So there was an argument there clearly that while the extent of the benefit varied with different studies, cell-based vaccines that year in studies in the US were better than egg-based vaccines. This is the adjuvanted vaccine that we are using at the moment in Australia for our elderly. It contains MF59, an oil in water emulsion composed principally of squalene. It increases the amount of activity locally, increased dendrocytic activity, increased antigen production cells, and both humoral and cellular immunity is increased. Lots and lots of studies, not studies of randomised controlled trials, but lots of studies about the real world impact of these. And this is one that I find particularly important. We had a look at 2017, 2019 on Queensland data and found out that there was a 60% reduction in big years in hospitalisations in 2019 using a adjuvanted vaccine compared to normal QIV in 2017. These are data from Sheena Sullivan's group published in Neurosurveil, and it's the first time I've ever seen that vaccine effectiveness in the elderly, in the 65 plus years, was in fact higher than vaccine effectiveness in other age groups. And one group, the elderly, had the adjuvanted and the other had the normal egg-based vaccine. So the trivalent high-dose vaccine data actually did have a randomised clinical trial that ran for 2 years over 2011, 12 and 12, 13. And this had a 25% primary endpoint relative efficacy compared to other vaccines, compared to the standard dose TIV. It did have a better impact in the first year, which was a H3N2 year, than in the second year. But overall, we saw a significant benefit in a range of people, including older persons, including people with high risks, and including people with frailty, which is very important in older persons in influenza. And if we look at a range of evidence associated with the high-dose vaccine, it was consistently more effective at reducing clinical outcomes, irrespective of the season, the circulating strain, and the antigenic match. And so that's high-dose vaccine on top. Going back to what we said, the 3 vaccines that are currently in use in Australia, the adjuvanted is on the NIP for those 65 and above. High-dose vaccines are available this year on the private market for those from 60 to 64. I mean, it's licensed from 60 and above, but obviously it's a paid-for vaccine, so we're not pushing it for people 65 and up who get access to the adjuvanted vaccine. And the cell-based vaccines available on the private market for 2 years and up. But I think for a range of logistical reasons has not had a huge uptake at this stage in Australia. So given that we have some beneficial vaccines that are better, but are still suboptimal from the point of view of giving us something that's more measles vaccine-like, what's the future for these vaccines? This is a busy slide, but it summarises some of the different types of vaccine strategies that are being used by different companies to try and actually produce a better mousetrap. We've talked about the cell-based approach, the baculovirus-based approach. I haven't put any detail into, given that it's not available in Australia at the moment, adjuvanted and so on. But I want to talk a little bit about the future, even though these vaccines are not currently available in Australia. And in particular, some of the pipelines of different companies. This is the Seqirus influenza vaccine platform. At the moment, they have a cell culture technology and an adjuvanted technology. They are at the moment producing and running trials on vaccines that combine the two, so that we would have a non-egg-based adjuvanted influenza vaccine. And they're also looking at trials of self-amplifying mRNA. This is their adjuvanted cell culture vaccine. It combines the benefit of the adjuvant with the avoidance of egg adaptation. They are currently looking at phase 2 studies, and phase 3 studies have commenced, although not in Australia, in 2022. They do have a monovalent adjuvanted cell culture vaccine licensed as part of the USA Pandemic Preparedness Program, based out of their Holly Springs. They're also looking at next generation mRNA vaccines, as are most of the companies. The difference between this and some of the ones that we're using at the moment is that the self-amplifying mRNA instructs the body to continue replicating the mRNA protein. And so the amount of antigen produced from a vaccine is less. The thought is that it will enable lower doses of RNA, so increasing production capacity, and potentially, they hope, reducing the side effects, although I think many of us believe that it's the lipid nanoparticles that are producing most of the side effects, and the reactogenicity of the current mRNA vaccines. They're starting phase 1 studies on those, and the difference between the two is shown here in this graphic, with self-amplifying with the replicase increasing the amount of antigen available in the cell. The baculovirus expression system used for flu-BOC and COVID vaccines by Sanofi has a number of benefits, but also some challenges. It allows for rapid production, gives a good genetic match to the antigen sequence. You don't need to work with the pathogen, and you can scale it up, all dependent on your bioreactor availability. The disadvantages are it's expensive, and there isn't currently enough infrastructure to scale up these recombinant vaccines. To finish up, I want to talk a little bit about the mRNA vaccines. These are the discovery of mRNA has been around for 60 years. It's been more recently that we've actually started looking at vaccination. 2012, there were some preclinical studies on flu and RSV. The RSV vaccines then, were continued to be developed, but really the big push came when we had the COVID vaccines developed in rapid phase in 2020. The issues largely related to reactogenicity in the early generation RNA vaccines, but we're now at a stage where we've got much better tolerability with still a high immunogenicity. We've managed to remove the need to store them at very cold temperatures and have a very short shelf life, and so that we've also got some efficient cell and organ specificity. So these vaccines are the future of a lot of the vaccine company responses against not just influenza, but RSV, number of cancers and so on. This is the data from Sanofi in some of their studies showing that they were actually capable of producing good immunogenicity at reduced doses and reducing the reactogenicity as a candidate. These are the pipeline for respiratory vaccines for Moderna. You can see that there are a range of mRNA vaccines that are already in phase 2 and almost in phase 3 studies. And there's a flu vaccine, the mRNA 1010, that is currently undergoing phase 3 studies. So we're excited that we'll be able to have a look at that, at the data for that soon. They've got RSV vaccines. They've got combined flu COVID vaccines, although a lot of those are still in preclinical development. And lastly, this is work being done largely out of the group in Nashville. They're talking about using genomics to actually identify specific vaccines for you tailored to your individual genomes, so that you'd actually go in there and, you know, get the vaccine that was designed from you. Greg Poland says that this is a way of actually decreasing the resistance of anti-vaxxers and also making this more powerful. I'll stop with this last slide. It's not much point having better vaccines if people don't actually go and get them. Our peak was in 2020, when we managed to get overall coverage up around 60%. Last year our numbers were terrible. Our paediatrics dropped substantially, and all groups dropped with the exception of a more minor drop in the over 65s. This year we started off very slowly, and we were particularly worried in June, but the actual arrival early of a nasty flu season meant that we ended up having an improved uptake over the course of the season, and it's now less than a peak, but at least it's better than it was. One of our challenges continues to be to make sure that people understand the importance of flu vaccines, albeit they're not perfect, and that they continue to go out and get vaccinated. I'll stop there. Thanks.
Thank you very much, Paul, for a really interesting presentation. We won't have questions now. We'll save all questions till the Q&A session at the end. So I think we can then move on to our next speaker. Our next speaker is Professor Tim Tam from lots of universities, University of New South Wales, University of Sydney, various affiliations that I don't have in front of me right now. That's okay. Tim, did you want to share your screen? Yes, brilliant. So Tim will be talking to us about influenza and cardiac disease. Thank you very much, Tim.
Thank you for that introduction. And I'm going to begin by just saying thanks again to Professor Rob Boy and the organizers for this invitation to speak on influenza and cardiac disease. So here are my disclosures. All right, so most of us are familiar with the fact that epidemics of influenza A or influenza B occur most years, usually during the winter months. So here's some Australian data which highlights the number of infections by month, with each of the colored lines representing individual years from 1992 to 2018. What is apparent is that the peak number of influenza infections consistently occur during the winter months. Now, the impact of influenza infections has also been on the rise over the past decade. Now, this graph on the other side shows that over all age groups, except in the under 1-year-olds, there has been a marked increase in the disability-adjusted life years per 100,000 between 2005, shown in light blue, and 2015, shown in dark blue. And what is most striking is that those who are 65 years and over tend to be most affected. Now, influenza is responsible for a significant number of hospitalizations and deaths in Australia over a 20-year period. So here, the general population has been divided into 3 age groups, with the very young in blue, elderly in dark blue, and the rest of the population in light blue. Now, these graphs show that the number of hospitalizations on the left and deaths due to influenza infections on the right are generally increasing across all age groups with time. Now, in 2017 alone, there were about 750 deaths among notified cases of laboratory-confirmed influenza within Australia. Now, to put things into perspective, how does influenza's impact compare with some of the other vaccine-preventable diseases that we are familiar with? So here's a graph featuring Australian data from the Australian Institute of Health and Welfare, which compares the burden of influenza relative to a number of other vaccine-preventable diseases, such as mumps, measles, rubella in Australia. So this graph plots the number of infections shown here on the x-axis to the number of deaths shown here on the y-axis. Now, influenza is shown in light blue, and what we can see is that when compared to a range of other common vaccine-preventable diseases here in Australia, influenza has the largest burden and causes the greatest number of deaths, hence one of the worst. Now, in terms of acute heart attacks, we know that respiratory infections can increase the risk of an acute myocardial infarct, as shown in this meta-analysis of a number of studies, which examine the link between respiratory infections and acute heart attacks. Influenza infections specifically are believed to increase the risk of an acute heart attack. So here on the right, we can see that peaks in the number of influenza infections appear to correlate with peaks in acute heart attacks. So certainly an influenza A or B viral infection have a 5 times or 10 times likelihood, respectively, of an acute myocardial infarction within 7 days of infection. Now, here's some recent data from a US study involving over 80,000 adults hospitalized with flu, showing that serious heart complications were common. 1 in 8 patients developed a sudden heart complication, with 1/3 of these patients eventually being admitted to the intensive care unit, of which 7% of these people died eventually. So let's have a look specifically at acute myocardial infarcts. What is the mechanism behind how an influenza infection can cause an acute myocardial infarct? Well, the pathophysiology is rather complex, as demonstrated by this diagram here. But the main point of this figure is to really highlight that the influenza virus, which are represented by these little blue dots, have the potential to contribute to the atherosclerotic process on a few different levels. In a nutshell, there is evidence which suggests that infectious agents play their atherogenic role by initiating or aggravating a chronic vascular or systemic inflammatory process. During the infection, there is an increased release of pro-inflammatory and pro-thrombotic cytokines, which may trigger destabilization of already present vulnerable plaques, leading to an acute myocardial event. Additionally, influenza infection can also cause a number of other cardiac and vascular-specific complications, including heart failure, arrhythmias, strokes, or acute exacerbation of chronic cardiac conditions. So in terms of the cardioprotective effects of influenza vaccination, there are 2 proposed mechanisms which are summarized in this diagram. Now, essentially, the non-specific effect shown here in black on the left demonstrates how vaccination reduces the secretion of inflammatory mediators, such as cytokines, which modulate a range of downstream effects, such as platelet activation and clot formation, adverse cardiac remodeling, and plaque rupture. Now, the more specific effect of vaccination shown here in the blue pathway on the right is where vaccination acts to inhibit pathways involved in the progression of atherosclerosis. So with these proposed mechanisms, where influenza vaccination may be cardioprotective, is there any real-world data to support the role of influenza vaccination in reducing influenza-related cardiovascular complications? Well, here we have some data from a randomized prospective cohort follow-up study done in the UK, which was supplemented by weekly national confirmed counts of influenza in the community. This study involved 24,535 patients aged 75 years or older from 73 individual general practices. This study showed an increased mortality rate during periods of high influenza infection amongst the unvaccinated patients compared to the vaccinated patients, suggesting a protective effect of influenza vaccination. Here we have some data from a large retrospective study from the US involving nearly 30 million adults and sourcing data from their inpatient NIS database, which highlights a decrease in prevalence of acute myocardial infarctions in patients who were vaccinated, shown in the green columns, compared to those who were not, shown in blue columns, with an estimated 10% risk reduction with vaccination. So tabled here are a number of other observational studies from various different countries, including Australia, demonstrating an association between influenza vaccination and a reduction in acute myocardial infarcts and strokes in patients without prior cardiovascular disease. Now, as a preventative strategy for cardiovascular events, influenza vaccination has also been found to be as effective as some of our other standard preventative strategies that we would normally target in our patients who have had a cardiovascular event, such as smoking cessation, statin therapy, and antihypertensive medications. Now, next, I'd like to focus on the impact of influenza on specific target populations who are most at risk and the role of vaccination in these populations. So this is a slide that I'd shown you earlier with data from the Australian Institute of Health and Welfare, mapping out the trends of hospitalization and deaths in Australia by year due to influenza infection. Now, this time, I'd like you to focus in on this dark blue line, which are the patients over the age of 65 years. There is a clear dramatic increase in the number of hospitalizations shown on the left and mortality rates shown on the right in this age group relative to the other age groups over the past 10 years, identifying those over 65 years as a group at risk. Now, do we have then any evidence for influenza vaccination in this age group who are clearly more vulnerable? So here's some data from Taiwan, which compared 135,448 elderly individuals with disability who were vaccinated compared with the same number who were not. This study reported significant lower risks of heart disease, hemorrhagic and ischemic strokes in those who were vaccinated versus those who were not. Here's data from another retrospective cohort study of elderly patients with a previous myocardial infarct from Taiwan, comparing 4,350 vaccinated with a similar number who were unvaccinated. This study reported reduced risk of recurrent myocardial infarction or cardiovascular deaths and hospitalizations due to heart failure, as shown here in these Kaplan-Meier curves. Likewise, in this other Taiwanese study, which was a matched cohort study of hospitalized stroke patients aged 66 years and older, those with influenza vaccination had lower post-stroke complications and mortality compared to those who were unvaccinated. These studies do highlight a possible benefit of influenza vaccination in this age group, or this risk group. Now, another population of interest would be those with chronic conditions. Now, apart from the direct impact of influenza infections on the respiratory system, there are also other reported effects of an influenza infection in those with chronic medical conditions, including worsening of their underlying chronic health conditions, which then results in increased disability, hospitalizations, and death. Now, this group are of particular interest to us cardiologists, as patients with heart disease also fall within this category. Now, in Australia, cardiovascular disease is the second highest cause for disability compared to all other chronic conditions. Here on the right is data from a US study which surveyed patients hospitalized with a flu infection, reporting that 85% had an underlying chronic condition, of which a significant proportion had an underlying cardiovascular condition. So do we have any evidence then for the benefits of influenza vaccination in this population? Well, here's a summary of some observational studies which have reported benefits of the influenza vaccination in patients with underlying pre-existent cardiovascular disease. Of note, the Ivve Trial, which was a double-blind randomized controlled trial of patients with chronic heart failure, shown here at the top, reported a reduced risk of all-cause mortality in those who were vaccinated. Another nationwide case-controlled study from Taiwan involving 11,374 patients showed an increase in developing atrial fibrillation and arrhythmia in unvaccinated patients. There are also some randomized controlled trials looking at the efficacy of influenza vaccination in patients with pre-existent cardiovascular disease, which showed a reduction in MACE, which included mortality, reinfarction, and rehospitalization for acute coronary syndrome. Now, most recently, there was an international multi-site randomized blinded controlled trial involving over 30 sites, including an Australian site, which looked at the effect of influenza vaccination in preventing a composite outcome of all-cause death, new acute myocardial infarct, and or stent thrombosis at 1 year in patients who have had an acute myocardial infarct. So to date, this is the largest randomized controlled trial with a 1-to-1 randomization to vaccination versus placebo, evaluating the effect of in-hospital influenza vaccination on death and cardiovascular outcomes. Recruitment started in 2018, and the intended number was 4,400. But unfortunately, the trial had to be terminated last year due to the COVID-19 pandemic. Now, the results of the Ime Trial were released at last year's European Society of Cardiology Congress as a late-breaking trial and published concurrently in Circulation. The trial showed that influenza vaccination reduced all-cause mortality and cardiovascular deaths following an acute myocardial infarct. Now, the results of the Ime trial has raised the question as to whether influenza vaccination should be in fact given to patients post-infarct prior to them being discharged home from hospital as a secondary prevention strategy. What about patients with heart failure? Well, shown here are the results from a nationwide cohort study from Denmark, which included 134,048 patients with heart failure. This study demonstrated that annual vaccinations, shown in the yellow columns, were associated with a 19% reduction in the risk of all-cause mortality, shown in blue columns, and cardiovascular death, represented by the pink columns. Another Israeli study involving 6,435 heart failure patients also showed that there was reduced deaths and hospitalizations with influenza vaccination. These Kaplan-Meier curves, where the blue lines represent those vaccinated and the red lines, those who were unvaccinated, demonstrated improved survival in those who were vaccinated. Now, the Ivve trial is a recent international multi-site randomized controlled trial involving over 5,000 patients from over 10 countries, particularly countries with low rates of vaccination, which looked at the question of whether influenza vaccination reduces mortality, non-fatal myocardial infarcts, strokes, and hospitalizations in patients with heart failure. The results of this trial were just released this year in April at the American College of Cardiology scientific meeting as one of the late-breaking trials. Now, in the Ivve trial, 691 participants had a composite primary endpoint of cardiovascular death, non-fatal myocardial infarct, or non-fatal stroke, and 1,470 experienced the composite co-primary endpoint, which also included hospitalizations for heart failure. Now, while there was no significant difference in the rates of these events between those who had received the vaccine versus those who had received the placebo, the rates of pneumonia and hospitalizations were clearly lower in those who were vaccinated. When we teased the data further, apart focusing only on the periods where influenza infection was most common, there was a significant reduction in the first primary endpoint, which was all-cause and cardiovascular death in those who were vaccinated. Now, in terms of other chronic diseases, here's some data again from the Danish nationwide cohort study, which demonstrated reduced cardiovascular and all-cause death in diabetic patients who were vaccinated. So, given the body of evidence, what are the current recommendations for influenza vaccination in these at-risk populations? Well, a number of professional bodies, including the Center for Disease Control and the Advisory Committee on Immunization Practices in the US, have recommended yearly vaccinations for those with chronic disorders of the pulmonary and cardiovascular systems. The American College of Cardiology and the American Heart Association have also recommended that patients with cardiovascular disease have annual influenza vaccination, citing Class 1 Level B evidence to back their recommendation. Likewise, the European Society of Cardiology and Heart Failure Society of America have made similar recommendations. But what about Australia? Well, in Australia, the Australian Immunisation Handbook recommends that all Australians aged 6 months or older with cardiac disease to have influenza vaccination. The Cardiac Society of Australia and New Zealand has put forward recommendations that patients with heart failure should be vaccinated, but there are presently no clear recommendations for those with acute coronary syndrome. Now, the Australian National Immunisation Programme, in line with the Australian Immunisation Handbook, makes the influenza vaccination available without cost to all those above 6 months with cardiac disease, who would cover those with congenital heart disease, those over 65 years, and those with chronic heart diseases. But despite these recommendations, there are suboptimal vaccination rates in patients who would benefit from it. The Paradigm HF study once again has provided some insights into uptake rates of vaccination. Of the 8,099 participants from 47 countries, there were quite low rates of influenza vaccination in a number of countries, particularly those in Asia. In fact, participants from 23 of the 47 countries had vaccination rates that were less than 10%. Data from Europe also reflects suboptimal vaccination rates. Here we can see that in a number of European countries, patients with chronic medical conditions had suboptimal rates of vaccination, which falls short of the EU target of 75%. In Australia, our vaccination rates can definitely be improved. These columns demonstrate the numbers within the various risk groups who would qualify for vaccination under the National Immunisation Programme, particularly those over 65 years and Indigenous adults. Of those who qualify for vaccination under the National Immunisation Programme, only a subset, shown in red, have been fully vaccinated. So how can we improve the rates of influenza vaccination uptake? We know that the underlying issues which serve as barriers to the uptake of influenza vaccination is in fact quite complex, as highlighted in this diagram, and potentially an interplay of multiple different factors, including determinants of health behavior, socio-demographic factors, psychological factors, and access to healthcare and context. There is still clearly a need for more research in this area in order to provide us with a more in-depth understanding of some of these factors, which would then allow for better informed strategies to improve vaccination uptake. Given the complexity of determinants affecting the uptake of influenza vaccination in cardiovascular patients, the strategies to improve the uptake of influenza vaccination will need to be multi-pronged, targeting multiple different levels. Not only will we need to target the patients and the providers, but we also need to look at the bigger picture of targeting the level of practice and policy. Proactive measures at the practice level, such as better strategies to identify eligible patients, team change interventions, such as increasing the responsibility of vaccine administration to members of healthcare teams like nurses, extending vaccine campaigns, minimizing missed opportunities, and targeting non-traditional settings for vaccination, like in the hospital, and targeting and having standing orders for the vaccine would help. There needs to also be a partnership with those who determine policy to integrate more global strategies which can impact the uptake of influenza vaccination. So in conclusion, I would like to leave you with a few take-home messages. Firstly, influenza is a significant health problem and is associated with cardiovascular complications. Secondly, influenza vaccination is beneficial in reducing influenza-related cardiovascular complications. Thirdly, most cardiac patients in Australia would qualify for influenza vaccination without cost through the National Immunisation Program. Fourthly, vaccine uptake in cardiovascular patients is a complex interplay of many factors, and there will need to be multi-level strategies to improve uptake. And finally, all healthcare providers should be proactive in raising and discussing the importance of influenza vaccination with our patients. Thank you.
Thank you very much for a very interesting talk. And I know that I actually have a lot of questions for you. So I'm looking forward to the Q&A time. So we will go straight to our next speaker, who is Professor Colin Masters, who's based at the Florey at the University of Melbourne. And he's going to talk to us about something a little bit different, talking about immunisation, but this time in the context of Alzheimer's disease. So welcome, Colin.
Thanks, Kirsty. Good morning, everyone. Great pleasure to accept the invitation to talk to the Immunisation Coalition. My full title of my talk is listed above. It's about late onset Alzheimer's caused by defective innate immunity and treated with adaptive immunity. But the short one for yours is passive immunisation for Alzheimer's disease. These are my disclosures. I have consultancies with most of the major companies that are the subject of this talk, but I have no personal financial remuneration or relationships with them. So we now are in a revolution in terms of a pre-mortem diagnosis of Alzheimer's disease through the use of selective molecular imaging agents, such as seen in this PET scan with a tracer for the A-beta amyloid, which accumulates as the signature pathologic lesion of Alzheimer's disease, and another tracer which is binding to the tau molecule, which is downstream of A-beta and accumulates in areas very similar to where the A-beta amyloid is accumulating. So I abbreviate in this talk this small peptide called A-beta. I'll just be referring to it as A-beta. In this movie, which is a concatenation of a series of these PET scans over a long period of time, but shortened to 30 seconds, you can see that in the upper panel, the A-beta increases and the tau follows. This is based on, obviously, on the two traces that I've just shown you there. To just show this a little more clearly, first, the A-beta accumulates in one particular area of the brain, roughly speaking, at about age 55, and then by the mean age of late 60s, early 70s, the cognitive impairment starts, and full-blown Alzheimer's disease with a centiloid of 100 starts at around 78 years of age. When we look at this data numerically, we see that the increase of amyloid in the brain over this 20-year interval is approximately 4% per annum, and that the lower threshold is illustrated down here, and the upper threshold, which is full-blown Alzheimer's disease, is over here. But the process in which individuals move from complete normality through to crossing the threshold also extends over a 10-year period. We think that this point here is about 45 to 50 years of age, and that this will be about 60. When we look at the principal causes of the buildup of this amyloid peptide in the brain, most of the GWAS studies are pointing very strongly to a series of genes encoding the phagocytic, autophagocytic pathways in professional macrophages, microglia, which are responsible for getting this material out of your brain, TREM2, CD33. Some of these molecules will be familiar to many of you immunologists. There are other pathways involved in getting rid of this material from the brain as we get older, active blood-brain barrier transport, bulk flow from the CSF egress pathways, localized proteolytic degradation, and the principal chaperones which bind to this peptide are also operative. The major risk factor for late onset Alzheimer's disease is apolipoprotein E, which comes as 3 different alleles, and it's the E4 allele, which is the major risk factor. Somehow these are all playing into the pathways that clear A-beta from the brain. And what seems to be happening is, as we get older, a series of somatic mutations of DNA mismatch repair accumulate in these critical genes, and that you have a failure of the clearance pathways by approximately 5% as you enter your 50s and 60s. That's enough to give rise to Alzheimer's disease. Now, I want to just focus on the restricted area of passive immunization. The actual molecular pathway involved in the genesis of the A-beta peptide, 42 amino acids in length, is that it's derived by proteolytic cleavage of a precursor molecule, partly in the extracellular domain and partly in the intracellular domain. The gamma secretases and the beta secretases release this peptide. We now have very potent compounds to inhibit the gamma and the beta secretases, but these have run into problems with side effects, which I'll mention briefly in my talk. But I want to concentrate where all the interest is right now, and that is either active or passive immunization against this peptide. There are other small molecules which are in development, which inhibit its aggregation. And just to get the active immunization out of our consideration at the moment, the early trials with active immunization with this peptide ran into major side effects because of the occurrence of encephalomyelitis, perivascular encephalomyelitis stimulated by active immunization with this peptide. So the adaptive and the innate immune system went crazy when you actively immunized and went straight for the blood vessels around which this peptide accumulates in the brain. That left us simply with passive immunization strategies. We've known since the early 1990s that people who are developing sporadic Alzheimer's disease make autoantibodies to this peptide. And more recent studies, which are shown in this data here, demonstrate the fundamental principle that the major immunodominant epitope of the A-beta peptide is in the unstructured N-terminus, whereas the more structured C-terminus, shown here in alpha helical conformation, is normally buried and invisible to the adaptive and immune system. So in these data here, you can see, for example, that as people develop amyloid in their brain, when they become PET positive, the circulating autoantibodies to the N-terminus increase, and the circulating autoantibodies to the C-terminus actually decrease. Now, this field is undergoing major revolution at the moment with the advent of passive immunization through the use of monoclonal antibodies targeting particularly the N-terminus of this peptide. Bapineuzumab was the first in class. That didn't work so well. It was used at too low a dose. The ones that I'm going to talk to you about today are aducanumab, gantenerumab, lecanemab, and donanemab. 2 others, which are against the mid-domain, a conformational epitope in the mid-domain, solanezumab and crenezumab, are still in development, but they are not as efficacious in the late onset forms of the disease once symptoms have developed. These antibodies are the ones that are now actively in clinical development. They're not all the same. The pathway in which the A beta accumulates, this is the monomer, 42 amino acid peptide, forms a tetramer, forms a fibril, which is elongated by growth, either at the growing ends of the fibril or in a phenomenon called secondary nucleation, in which these oligomers, tetramers, can grow off the side of the fibril. We now know that the different antibodies that I'm about to describe to you act differently. Gantenerumab, for example, affects the growth of the attachment of the monomers and the oligomers to the growing tips of the fibrils, whereas aducanumab seems to have its effect principally on the secondary nucleation events. So not all monoclonal antibodies are the same, they work differently. This field was galvanized by this picture on the front page of Nature in 2016, in which one particular autoantibody, this is aducanumab, this is the first ever human autoantibody, which was cloned from a single B cell and then commercialized from a single B cell into a commercial product, was shown to reduce the PET signal in this fashion, where after 1 year of reasonable high dose aducanumab, you can see the PET signal dramatically declined. Placebo, 3 mg per kg, 6 and 10. Not only did the PET signal for the A beta decline, but the PET signals for the downstream tau molecule also declined in a subset of individuals who were examined with this newly evolving technology. You can see here baseline follow-up in 3 different individuals. You can see a reduction in the PET signal for the tau molecule. This and led to the unprecedented accelerated approval by the FDA in June of 2021 of aducanumab under the trade name Aduhelm, marketed by Biogen, the discoverers of this single autoimmune cell-derived human autoantibody was Neuroimmune Company in Zurich. This was met in the field with great controversy because of the relative lack of clinical efficacy, although there was a major signal in the reduction of the PET scan. But the FDA held firm to its opinion that as a surrogate marker of efficacy, a reduction in the PET signal was enough for it to give it accelerated approval. Much to everyone's consternation, the major insurers in the United States, the CMS, said, we're not going to pay for this. We're going to wait and see how the field develops. So as of June this year, we were left in a situation where we saw significant relationships of lowering A beta in the brain with aducanumab. There was a clear-cut 25% slowing in the rate of clinical impairment. The calculated clinical effect was pre-specified as a 25% slowing in the rate of cognitive decline, which the FDA and the company, Biogen, agreed before the trial started would be taken as a sign of clinical efficacy. But as I've said, the payers in the US said, no, 25% is not enough. What they were looking for was a 62 or even 125% slowing in cognition impairment. And the FDA took the position that that was a totally unrealistic expectation for a first-in-class drug and the first disease-modifying drug ever for Alzheimer's disease. So Biogen packed its bags, put this particular monoclonal onto ice, and joined forces with its partner, Eisai. Before I talk about that, I'll just talk about Roche. Roche also have a monoclonal antibody, which will read out in a phase 3 study in September next month. The Roche has been working on this particular form of passive immunization for Alzheimer's for nearly 20 years. There's a very strong reduction of 60% in the PET signal. There's clear in the early phase studies, it's clearly slowing the rates of clinical decline. And we're all very optimistic that something good will come from the phase 3 study, which is about to be released. As I said, Biogen packed up and joined its long-term partner, Eisai, with another antibody called lecanemab. Lecanemab is directed also to the N-terminus, slightly different from aducanumab. It has a very effective rapid reduction in the PET signal. And we already know that lecanemab correlates with, administration correlates with a clinical slowing and decline. It has a very low incidence of side effects, which are known as ARIA-E, the amyloid-related imaging abnormalities, edema. And this is now also going for accelerated approval. The third antibody, which is now in development and is expected to get to the FDA later this year or early next year, is donanemab. This is a new epitope. This is a pyroglutamate modified N-terminus of the A-beta, which surprisingly lowers all forms of A-beta accumulation in the brain. A very, very rapid reduction within 24 weeks of being administered, and a significant relationship. And all of these antibodies also lower the tau signal as measured on PET scans and on blood biomarkers. So this is in summary of what these major antibodies look like over a period of time, 0, 6, 12, 18 months in these phase 3 studies. They all are effective at lowering the PET signal. And when you look at all the data and you look at the degree of which the PET signal is reduced and correlate that with the degree of reduction in the rate of cognitive decline, you can see this clear-cut relationship. This was the figure that allowed the FDA to give accelerated approval to aducanumab. But it wasn't enough, as I've said, to convince the payers. So where are we heading at the moment? This is only the beginning of disease modification for Alzheimer's disease. I think that we're going to be looking at combination therapies, such as we see in oncology at the moment. In this particular instance, I believe that we're going to see the use of these antibodies in clinically impaired individuals, people in the prodromal or the clinical stages, where the antibody is given to lower the PET signal to baseline, and then some other form of inhibitor of production or aggregation will be used either alone or in combination as a maintenance therapy. In individuals who are asymptomatic, we are now extremely optimistic that these forms of disease-modifying therapies, if introduced at the very earliest stages, that is when people are either at genetic risk or are visibly crossing the lower threshold. We are in a position to institute clinical trials right now for secondary prevention for those people who've crossed the threshold, or primary prevention, well, people who are carrying particularly the ApoE4 main genetic risk factor for late onset disease in a primary prevention. These studies are now underway, and it'll take another year or two, but we're extremely optimistic that this form of intervention will be far more efficacious in these individuals before the onset of clinical symptoms. These are my acknowledgement slides. Most of the data I've shown you here, a lot of it is the natural history is derived from the Australian Imaging Biomarker and Lifestyle Study. These are my collaborators, and I will stop sharing my screen. Thank you.
Thank you very much for a really thorough and interesting presentation. So we've got lots of questions, and please send through questions, more questions as you have them. So I think the first question we have is for Paul, and it's just a simple confirmation question from Michael Woodward, who was wondering, or who thought that we were using the quadrivalent adjuvanted vaccine in older folks this year. Is that correct?
That's correct.
Okay, that's an easy question. So the next question we might as well go on for you as well. Sorry, Colin, you had something you wanted to add to that?
Well, I've got a couple of questions for my influenza colleagues, but if you want to just stick with the chat box, that's fine as well.
No, we will go as dynamic as possible and go through the chat box as well. So if you want to launch a question, go right ahead.
Yeah, I've got two questions. One is the pandemic of 1918 and 1919. Do you, as influenza experts, think it was the influenza virus that caused the sleeping sickness of Monoclonal, or do you think it was some other virus?
Look, I don't think there's any data to support going either way from that. It was certainly different to more recent influenza pandemics in that it tended to affect younger groups. It tended to have a higher transmission process within, but it was complicated by troop ships coming back from the First World War and a whole lot of other issues at that particular time. And I don't think that we've got any data on what the likelihood of its role in other presentations was.
Okay, I've got one more question for Tim.
Sure.
Tim, the coronary artery is pretty much the same structure as cerebrovascular, one of your anterior cerebral vessels. So, the incidence of stroke should also be increased in influenza. It would add weight to your argument. Is there any evidence of increased atherogenic stroke with influenza?
So yes, there's definitely been an increase in incidences of stroke, certainly embolic strokes more so than hemorrhagic strokes. But whether it's actually a direct contributing factor from the atherosclerosis is not so clear, because influenza also increases your thromboembolic phenomenon or burden. So it could be due to formation of clot, and then the clot sort of going up to the brain and causing the stroke, but it could also definitely be an atherosclerotic process within the actual blood vessel itself. So which one we attribute it to is definitely hard to say specifically, but both mechanisms can give rise to stroke. And that's certainly spikes of increased incidences of stroke when you have influenza vaccination spikes.
Yeah, but your average coronary artery is a thrombotic event, isn't it?
Yes.
So you would expect to see similar thrombotic events in the brain.
Yes, we would expect that, but because in stroke, some of the pathology comes technically from embolic phenomenon from somewhere else in the body, we cannot definitively exclude that as a potential too.
Okay,
and I don't think this only applies to respiratory viruses. I mean, there is good data now that suggests that people who get shingles have an increased risk of stroke after shingles, so this is a post-viral phenomenon rather than a post-respiratory viral phenomenon.
All right, so we might go for a question to Paul now. This is from John Litton. I think it's a very topical question. Is there any development in the development of mucosal vaccines for flu?
Sorry, say it again.
Where are we at with the development of mucosal vaccines for flu?
The new, which vaccines?
Mucosal.
Oh, look, I'm not sure that they're any further progressed than any of the others that we've spoken about today. There's certainly some work being done on that, but I don't think any of them are beyond preclinical or phase 1 trials.
And what sort of happened to flu mist? Because I remember so much optimism around flu mist, and it never really panned out.
Yeah, so I did cover that as LAIV in the talk. So flu mist was
Okay.
live flu vaccine. It was there was a lot of optimism, and it's still used for all children in the United Kingdom as part of their 6 months to 18-year program. It obviously had some benefits because you could go into a school distributing this without needles and all of the rest of it. But the challenge was that it had a few years of really bad data in the US, and it was taken off the accessibility. There was a recommendation against using it for 2 or 3 years while they collected extra data. And, I think it's the challenge with flu that sometimes we have randomized controlled trials, that are very tightly managed and restrict who goes into them. And then we have real world data, and they don't always map out to be the same as randomized controlled trials. And that's particularly for flu, which has a whole lot of impacts on older persons with chronic diseases and so on, who tend not to get into trials. And so I think that's, one of the challenges. I'm a firm believer that we need to look at real world evidence for vaccines that we're using in older persons.
I think that's an excellent point. It's something that probably resonates with everybody here. I might turn to Colin and ask a question that's been posed by Wendy Cannon. How can individuals access the Alzheimer's drug program if non-symptomatic but have a family history?
Yeah, so these are studies which are now in progress. So people who are interested in this should join clinical trials. There are clinical trials rolling out, not only for sporadic late onset disease, but also for people with autosomal dominantly inherited Alzheimer's disease, which is young onset forms, and people who have increased risk because of the ApoE gene in pre-symptomatic disease. So these studies are rolling out, and go talk to your local physicians who are running these studies.
Okay, I might ask myself a question because I can, and I'll invite all the clinicians in the panel to actually comment on this. Why can't the Australian government fund flu vaccines for obese individuals at least? Currently only a recommended vaccine. Surely there is a cost benefit. Look, I really, really hope that this year has set the precedent that flu vaccines should be free and available for all, because this is what we need. It's not just obese individuals, it's not just overweight individuals. The reality is the majority of us fall within one or more comorbidity that makes us vulnerable to more severe flu. So I think it should be a standard government policy now to make flu vaccines available for free for all. Tim, I don't know if you wanted to comment on that.
Yeah, I think this year it's actually free for those who are obese with a BMI over 30 kilograms per meter square. It's actually available for free. These people are definitely at risk of complications, medical risk of complications. So they definitely can receive it for free this year. But hopefully that will continue on into the future as well, because there's clearly a benefit and, as alluded, a cost benefit too.
Definitely. Colin?
Thanks. I've got a question for Kirsty as well. So,
great.
Long COVID, people with diabetes and obesity. Did you mention that? I wasn't clear on that. I mean, clearly long COVID exists, and nobody quite understands what it is. Is it increased with people with obesity or not?
Yeah, this is something that we're actively researching, but generally, and it's consensus across several different countries, studies, that obesity is a risk factor for long COVID. Now, the risk factors for long COVID do vary depending on the study, and that largely reflects the fact that our definition of long COVID is very, very variable. Some studies say it's symptoms after 4 weeks, some say 8 weeks, some say 12 weeks, some say it's one set of symptoms, some say it's another set of symptoms. But certainly obesity does seem to be a risk factor. In my mind, that may reflect the role that chronic inflammation plays in long COVID. And this is actually something that we are looking into in the lab. But I'm in particular very interested in sort of the long-term cardiovascular complications that COVID will have. So Tim, maybe you can comment on that.
So I think in the cardiology community, it's seen as any symptoms persisting beyond 3 months. But again, it's nebulous, not hard and fast, but it's generally agreed 3 months. The manifestation of the symptoms are quite varied. We can have people, complaining of persistent chest pains, palpitations, shortness of breath, a whole plethora of symptoms that you can't, it's very sort of vague. And it's thought that because of this, it's likely to be a multi-system sort of a problem. In terms of pathogenesis, we don't really know specific. There's not enough known about what actually causes these symptoms. But what we do know, certainly from what we understand from how the virus invades cardiomyocytes, it kills them. So definitely there is some sort of damage that is inflicted. And there are some sort of concerns that we may be looking potentially at a heart failure epidemic in the near future, given that this actually impacts on so many people. Our tools for detection of damage, potentially there might be some echocardiographic parameters, perhaps even some MRI sort of imaging parameters that have looked at this. But again, the data for this is quite limited. So we don't have a great sort of handle on this as yet. But I think as we move forward and as it starts to manifest a little bit more, I think we will be seeing a little bit more in this space.
Yeah, but the pathologic evidence for long COVID is underwhelming. It's like it isn't there.
I think a lot of the immunology, you see that there are clear differences in terms of studying the immune system. That's not pathological, but I think there are clear differences biologically that you can see with individuals with long COVID. You
mean as a cellular immune deficiency after?
Yeah, so at a cellular level, there's now just been a very interesting paper coming out showing very low cortisol levels in individuals with long COVID. So I think there are biological readouts of long COVID. I think we just don't understand a lot of it yet.
And I mean, up to 30% of people with COVID infections have reported long COVID symptoms. It's quite a significant number. But I mean, the tangible ones that have manifestation as a marked, heart failure sort of drop in EF type of thing is not quite so much. But again, it could just be that, it is there, but our tools are not designed to pick that up. But we don't have sophisticated enough tools to pick up the subtle damages, and how this will translate into more long-term effects in the future is yet to be seen, because we're just starting to see this as an entity emerge in the clinical space.
And we're getting a comment on the chat from Tony Cunningham saying that there is unpublished data, and actually I've seen published data on the CSF changes. So there is some changes. I think we've just got a lot to learn. I guess following on from the sort of COVID discussion, I'd like to ask Paul if he thinks, with COVID-19, there was so much consumer choice, I guess, with vaccination. And, people were really demanding, I want my Novavax or I want my mRNA vaccine. Do you see the same thing sort of happening with flu now that we have a wide variety of different flu vaccines available?
I don't think it's continuing. Certainly what we saw after the introduction of QIV was, despite, relatively low increased benefit of adding a second B strain into the vaccine, for probably anybody other than possibly children, the government, when they released it, pushed it as a real enhancement. And the government was saying, look, we're giving you this new improved vaccine. And at that stage, I saw a lot of people come into clinic to check whether they were getting the 4 strain compared to whether they were getting the 3 strain. But most people now who are accessing influenza vaccine don't actually have a specific preference. You need to make sure that older persons get the enhanced vaccine, the adjuvanted vaccine, and don't go, earlier when it's not available yet to a chemist and get unadjuvanted vaccine, which has been a problem in some time. But, this year we really did have a boost to our vaccination rate, which came because many of the jurisdictions were concerned about poor coverage and very high flu numbers in May, June, and made it free for everybody at that stage. And it really did produce a pickup, partly because of the message that flu is bad all of a sudden. So I know you've only heard about COVID for the last 2.5 years, but flu's back, and partly because it was free. And there's been a general belief in the public that having a vaccine that's not funded means it's not important. The government funds so many vaccines that if they don't fund flu for me, then it can't be important for me. Whereas, it'll be interesting to see whether having spent literally billions of dollars on COVID vaccines over the last 18 months, whether they are now committed to improving access to other vaccines, such as flu vaccine for all, such as pertussis vaccines and enhanced shingles vaccines and so on for older persons, or whether they go the reverse and decide we've spent so much money on vaccine, let's spend it on something different, like improving aged care or improving waiting lists or so on. So I think we're at a real crunch point on what they're going to do with vaccines moving forward. But I'm hopeful that universal influenza vaccine is part of what we get moving forward.
Thank you very much. I think that should... Oh, sorry, Tim.
Yeah, I guess I was just going to add the other point that there's also data to suggest that a co-infection with both influenza and COVID-19 is actually increases your mortality rates almost double, in fact, quite significantly. So again, there's impetus to try and get vaccinated against at least both of them, if not the flu.
It was the push we used in 2020 to get very high numbers when we didn't have a COVID vaccine. We got 18 million people vaccinated against flu because we were talking about the twindemic. What's been interesting is that I didn't see anywhere near the number of people with co-infections at the peak of influenza as I was expecting. And in other countries, there was some data out of the UK that suggested that the reason for them not getting a flu outbreak, when in fact they didn't have border closures and they had a prime minister who went and shook hands of people with COVID, was because there was some competition between the viruses, and that the extent of COVID was actually preventing flu from coming in, whereas what we've got in Australia was extensive COVID and a big flu outbreak, probably our third largest over the last 3 decades.
So I could continue talking on this for a long time, but I'm afraid I'm going to have to close the session. So I would like to thank all the speakers for their fantastic talks and insights.